Good morning. I'm going to talk really quick because I know we're already over. But I organized this session, or this talk. It's by Camille Moore, who just finished her master's thesis, and yesterday just submitted her first NIH grant. Okay. And also Dr. Liz Connick, who I've worked with for years. I wanted Liz to be involved because I wanted her to show how our statistical methods research is really related to public health and how it's bringing statistical methods that we've developed into making better understanding of HIV disease progression. So I'll turn it over to Camille and Liz.
Today I'll be talking about accounting for dropout reason in longitudinal studies with non-ignorable dropout and an application to the association of injection drug use with HIV disease progression. And while Dr. Connick and I will be presenting, I also wanted to thank our collaborators, Dr. Mawhinney, Dr. Forster, and Dr. Carlson, as well as the ADRIP study group. Longitudinal cohorts are a valuable resource for studying HIV disease progression. However, dropout due to loss to follow-up or death is fairly common in these types of studies. Individuals with poor clinical outcomes, such as those who use injection drugs, are more likely to drop out, and therefore they're also more likely to be removed from analyses. Over time, these cohorts can evolve to be biased towards subjects with better outcomes and healthier lifestyles. Traditional longitudinal data analysis methods, such as mixed models, do not account for non-ignorable dropout and can lead to overly optimistic estimates. Dropout is a particular problem when we're studying the association of drug use and HIV disease progression. While a lot of basic science studies have suggested that a pretty wide range of drugs and alcohol can impair the immune system and increase HIV virus replication, epidemiological studies haven't necessarily found these same results. And sometimes the studies have found no association between drug use and HIV disease progression. Some have found harmful effects, and some have even found protective effects of drug and alcohol use, which would be pretty surprising. We hypothesize that these conflicting outcomes may be due to a failure to account for non-ignorable dropout in the analyses, which would bias the results towards subjects that completed the studies. And again, these subjects are more likely to have improved outcomes and are less likely to engage in high-risk behaviors like drug and alcohol use. We previously developed a semi-parametric natural cubic B-spline varying coefficient method to account for dropout time. And part of what we did in my master's thesis was extend these methods to also account for dropout reason. And you can imagine that subjects that drop out of a study for different reasons could also potentially have different outcomes over time. So for example, someone who dies during a study is probably having faster disease progression and poorer outcomes than someone who simply lost a follow-up and doesn't feel like coming back for their visits. So I won't go into all of the terrible, horrible statistical details, but, but the basic idea is just that we let a subject's outcome trajectory over time depend on his or her dropout time and the reason that he or she dropped out of the study. So now I'll talk about our application to the Acute Infection and Early Disease Research Program data set. And this program was a multi-center observational cohort study of patients that were acutely and recently infected with HIV at enrollment. Subjects in the study were allowed to self-select whether and when to begin antiretroviral therapy, and CD4 T-cell count, which is a measure of immunologic function, was collected at baseline and then again at several points throughout the study. We hypothesized that the untreated HIV-positive injection drug users would have faster declines in CD4 count than untreated HIV-positive patients that did not use injection drugs. And we also thought that it was possible that viral set point could mediate this relationship. So during the chronic stage of HIV infection, there's a relatively stable amount of HIV virus in the blood, and it's been shown that that amount, which is known as the set point, the higher that is, the worse the clinical outcomes and the faster the disease progression. So we thought it was possible that injection drug users might have higher levels of virus, which would cause their worse outcomes. So here are just some basic descriptive statistics. We had about 1,000 subjects included in our analysis, and this was mostly a cohort of white males. There was evidence for potentially not ignorable dropout in the data set. We looked at data from baseline to 3 years for the subjects, and we cut off at 3 years because there are very few patients that decided to remain untreated past the 3-year time point. So patients didn't have full data either because they started treatment or because they were simply lost to follow-up. So we had these 2 different dropout reasons in the data set. Additionally, we saw in this box plot that the injection drug-using subjects tended to drop out a little bit earlier than those who didn't use injection drugs. And then also looking at each individual subject's kind of trajectory of CD4 count over time and comparing that with their dropout time, it seemed that those who were dropping out early were having more rapid declines. So definitely we wanted to take dropout time and reason into account in our analysis. So we used these new methods that we had developed in order to model CD4 count, which is that measure of immunologic health, over time. And our primary explanatory variable was, of course, injection drug use. And we included several different covariates in the model, age, race, sex, the infection time, as well as the nadir CD4 count, which is sort of the minimum amount of CD4 count or the minimum CD4 measurement during the early stage of HIV infection. To assess mediation, we included a viral set point and viral set point by time interaction in the model and assessed whether our impact of injection drug use changed once we accounted for viral set point. So here are some of our results. And what you see in the graph, the top 2 lines are for those patients that were lost to follow-up. And the filled-in triangles are the lost to follow-ups that were using injection drugs. And then the bottom set of lines is for the patients that started treatment. And again, the filled-in squares are the injection drug use group. And so within both dropout reasons, we see that injection drug users are having more rapid declines in CD4 counts than the non-injection drug users. So overall, sort of averaging over both those dropout reasons, we saw that injection drug users' CD4 counts declined by about 32% each year compared to 25% for the non-users. In terms of our mediation hypothesis, we actually didn't find any evidence showing that that HIV-1 RNA or that viral set point could explain the effect of injection drug use. So viral set point explained only 2.4% of the effect of injection drug use that we saw in the analysis. And so that's sort of surprising. So hopefully Dr. Connick will be able to propose some other mechanisms by which injection drug use actually impacts CD4 count. And lastly, I wanted to point out that the magnitude of the association between injection drug use and CD4 count decline that we found was 36% larger using these methods that accounted for dropout compared to using a standard linear mixed model. So at this point, I'm going to hand things over to Dr. Connick so she can talk about the clinical implications.
Thanks, Camille. So I'm Liz Connick, and I am an HIV physician and also a researcher. I'm an immunologist, and I do both clinical and laboratory-based research. And I was one of the ADERP, the Acute Infection and Early Disease Research Program investigators, so I know this data set pretty well. I want to give you some context or
interpretation of Camille's results from a clinician and an immunologist point of view. So this slide here is a schematic of the natural history of HIV infection in untreated individuals. Fortunately, now we have antiviral treatment, and CDC recommendations are that everyone should be on it. But this is what happens when people aren't treated. On the x-axis here is shown time after infection. On the left y-axis is CD4 T cell count in blue, and on the right y-axis is viral load. And following infection, individuals develop a high level of viremia that settles down as the immune response kicks into what is known as the virus set point. And the virus set point is a quasi-steady state that is usually fairly stable over a period of months, but slowly increases over time. The blue line here shows the CD4 T cell count, which, the decline in CD4 T cell count is the hallmark of HIV infection. Loss of CD4 T cells is the fundamental immune lesion that produces immune deficiency, ultimately resulting in opportunistic infections and death. And in the absence of treatment, the average time to developing AIDS, opportunistic infections, is about 8 years, and to death 9 or 10 years. Although there's substantial variability, some people progress to AIDS in less than a year, and other people are alive at 20 years. So what we've learned is that the plasma viral load is a very strong predictor of the rate of disease progression. And these are data from the multi-center AIDS cohort study from 209 men who seroconverted during the course of the study. So their baseline viral load after they seroconverted was presumably their set point. And using these data, you can see the relationship between set point and disease progression. These men seroconverted in the 1980s before we really had effective antiviral therapy. So essentially, this was a natural history study. On the y-axis here is the percentage of individuals who survived after 6 years after infection. And on the x-axis are the 4 quartiles of viral load, the lowest quartile on the left and the highest quartile on the right. And what you see quite clearly is that your viral load following seroconversion was a strong predictor, with those in the lowest quartile, over 90% were still alive at 6 years, whereas those in the highest quartile, only 40% were alive after 6 years. So it may come as a surprise to you, but actually, despite the fact that loss of CD4 T cells is the fundamental lesion in HIV, there's a large amount of controversy over what causes the CD4 T cells to go away. I think the most obvious ones, and that everyone can think of, well, clearly the virus infects a CD4 T cell and it kills it. Or else the immune response eliminates it. HIV itself actually increases probably the number of target cells and their susceptibility, which renders them more susceptible to both of those other mechanisms as well. But there's a lot of evidence that there's other causes for CD4 T cell loss in HIV-infected individuals as well. When we measure the CD4 T cell count, we're only looking at peripheral blood, which contains actually only 2% of the CD4 T cells in the body. The rest of them are in other tissues, particularly the spleen, lymph nodes, gut-associated lymphoid tissues. And there's actually very clear data that some of the decreases actually are a result of sequestration of CD4 T cells from the peripheral blood. They get sequestered into the lymphoid tissues. The thymus is an organ that produces new CD4 T cells, and there's some evidence that that individuals in HIV may have impairment of their thymic function. Everybody has what we call homeostatic proliferation of their peripheral blood T cells that just divide naturally, spontaneously, and help maintain our CD4 T cell count. And then it's pretty clear that HIV-infected individuals have impaired cell survival, even of cells that are not infected, possibly due to chronic immune activation, which makes them more vulnerable to cell death. So intravenous drug use has been proposed actually to have an influence on all of those mechanisms. One other thing I want to point out is these three you would expect to be mediated by viral load, whereas the others you would not expect to be mediated by viral load. So intravenous drug use has been proposed to influence CD4 T cell counts in a variety of ways. Cocaine has been shown to increase chemokine receptor expression, which increases susceptibility of the cells, as well as probably induces more target cells through activation. Drug users probably have significant impairments in immunity just from chronic stimulation of their immune system with the foreign antigens that they shoot into their bloodstreams. There's clear evidence in mice that cocaine impairs the thymic regeneration of CD4 T cells, and drug users likely have some impairment of their survival of CD4 T cells. And lastly, it's probable that at least some drug users have sequestration of CD4 T cells due to cirrhosis and inflammation. So I think what's important about Camille's work is, first of all, showing that non-ignorable dropout really demonstrates that drug users had worse outcomes, gives credence that this is actually true, that these mechanisms may be occurring. Furthermore, the top two we would expect to be mediated by viral load, but we didn't see the viral load mediation in her study, which points us more in this direction. So I think we'd like to validate this in another cohort, but if we do, I think we'd really like to design further studies to see if we can tease out these various mechanisms. Thanks. And
I'm supposed to cut you off at this point.
I'm done.